So we're back to the usual osteoblast. We're on part 9. I did not envisage that I'd be doing so many when we started back in March, but it's been quite useful, I hope, for you. So today, the ones in red are the ones that we've already done so far. Today we're going to cover what do I advise if the patient needs dental work and is on an anti-resorptive. So by anti-resorptive, I mean the bisphosphonates or denosumab. So these are the two classes of drugs that typically have dental complications. Okay, and what to do if the patient fractures on a bisphosphonate. So this is quite a common referral from GPs. This patient's on alendronate and has now fractured their wrist. What do you advise? So I'll talk a bit about that as well. And I'll also do a quick bonus revision session at the end to cover some of these topics that we've done before, just the key things, rather than move on to more new stuff. So here's our interactive case. So a 76-year-old woman attends the endocrine clinic. She's been on alendronate for 6 years, but she now needs a dental extraction urgently. So an invasive oral procedure. She is very anxious about the high risk of complications that she's read about in the Daily Mail. She has no other risk factors for osteonecrosis of the jaw, but her dentist has said that he will not perform the extraction unless the alendronate is stopped. Now, I suspect that quite a few of you will have come across this scenario where you're basically asked for a dental opinion on a patient that you've been given bisphosphonates to. So the options here are agree that there's a very high risk of osteonecrosis of the jaw and should stop the alendronate immediately, switch to denosumab, continue the alendronate, maybe because the mechanism is fairly similar between osteonecrosis and atypical femoral fractures, should you just screen for an atypical femoral fracture by performing a hip x-ray, or should you switch to the other slightly shorter acting bisphosphonate risedronate? So those are the options. Let's see if I can get Mentimeter up now. Hopefully that has done it. Can you see the Mentimeter? Sorry, Kareem. Can you see the Mentimeter? Sorry.
No, we cannot see it.
Okay, let me just try again. If I go to that. No? Okay. Stop share. And then show screen. Okay. So here are the options. 76-year-old, alendronate 6 years, tooth extraction needed. What are you going to advise? So high risk of osteonecrosis of the jaw. Let's stop the alendronate. Let's switch to denosumab. Let's continue the alendronate. Check for an atypical femoral fracture with a hip x-ray, or switch to risedronate. Okay, so let's see what you've been saying. Okay, so that's a nice split between stopping the alendronate and continuing the alendronate. Switching to denosumab, there's no real benefit in this scenario, in this urgent scenario, obviously, because that will also cause osteonecrosis of the jaw risk to go up, probably a slightly higher risk. There's no real benefit to check for an atypical femoral fracture because she's not complaining of any groin pain or thigh pain, which may make you think of an imminent atypical femoral fracture. Switching to risedronate at this late stage, when she urgently needs treatment, would not make any difference. If you had someone with dodgy teeth, you may decide to put them on risedronate rather than alendronate to start with, because it washes out faster from bones. So that's why the bisphosphonate holiday for risedronate I typically use is 18 months rather than the 2 years that I use for alendronate. So a good split between stopping or continuing the alendronate. So let's go back to the slides. So I would continue the alendronate, and I will basically talk to you why shortly. So as I've shown you before, your risks of osteonecrosis of the jaw when you've had 10 years of bisphosphonate exposure are extremely low and much lower than your chances of being run over walking in the street, and lower than your chances of being murdered in the US, as the caveat. But you can see here very small chances. Maybe you've got a slightly bigger chance of atypical femoral fractures when you're on 10 years of a bisphosphonate. But these are very low risks as opposed to your benefit. So that's the difference between the red and the blue bars for all these types of fractures. So if you're on treatment, that's the blue bars, and if you're not, it's the red bars. And you can see these are the advantages of being on a bisphosphonate. So just again to stress the small risk of osteonecrosis of the jaw. So what is osteonecrosis of the jaw? Well, firstly, I always tell patients that it sounds much worse than it actually is in the most commonly encountered form, which is the mild form. So essentially, osteonecrosis of the jaw is non-healing wound in the oral mucosa with exposed bone lasting more than 8 weeks. So it's basically exposed bone lasting more than 8 weeks in the oral mucosa. It can be divided into mild, moderate, and severe. So this is stage 1, 2, and 3. And here are some pictures. So this is mild. I've seen a couple of cases of this so far in my career. This is the most commonly encountered form, mild osteonecrosis of the jaw. Okay, moderate. You can see it's starting to. There are more areas of exposed bone, and then obviously the severe. Okay. With mild and moderate, in most cases, all they need is antibacterial mouthwash, in some cases oral antibiotics as well on top. But that's why we should always be telling our patients who are on anti-resorptives that they should ensure good dental hygiene. I normally recommend that they use a mouthwash twice a day because the mechanism is often a little bit of dental infection around the gums, and that starts to erode a bit the bone, and then the bone doesn't heal properly, and that becomes the osteonecrosis of the jaw. It doesn't heal properly because you've suppressed bone remodeling with your bisphosphonates and your denosumab. So I always tell patients to ensure good dental hygiene and use a mouthwash twice a day and take it from there. More severe forms, obviously, they often need a debridement and potentially resection. This is extremely rare with these treatments. I've never seen a case or had anything other than mild osteonecrosis of the jaw in my patients so far. So often dentists are very nervous when doing dental work in patients on anti-resorptive medication. And I do understand this, but this has now been sort of covered quite conclusively, and the risks, benefits have been assessed. And these are some guidelines from NHS England. These are actually not from endocrinologists or rheumatologists, but from the other side. So these are actually from the oral and maxillofacial surgeons, their guidelines. And they do acknowledge here, so in the first red box, they say BRONJ, so that's bisphosphonate-related osteonecrosis of the jaw, BRONJ. And there's actually a BRONJ clinic at King's where they see all these patients, and I occasionally refer a patient there. So this is a very rare condition, and it is important that patients are not discouraged from taking bisphosphonate drugs or from undergoing dental treatment. Okay, that's very important. The risks are so small that they are outweighed by these great benefits of these drugs. And then look at this second box here. There is no supporting evidence that the risk will be reduced if the patient temporarily or even permanently stops the bisphosphonates prior to the invasive dental procedures, as the drugs last for many years in skeletal tissue. Okay, if a patient has taken bisphosphonates in the past but is no longer taking them for whatever reason, allocate them to a high-risk group. So essentially, this, if you're told, if a patient says to you, oh, the dentist says I need to stop my Lengenix, I'm having a dental extraction next week, that's pointless, essentially, because the drugs last in the skeletal tissue in the bone and will continue to impair bone remodeling for years. And so in the urgent situation, there is no benefit. Okay, you can let it wash out. You can give Alendronate 2 years to wash out, have most of its effect washed out, and Risedronate 18 months and Zoledronate 3 years. If you can wait that long, that's fine. Then there'll be minimal remnant effects of the bisphosphonates on bone turnover by that point. But in the acute setting, they might as well just continue. Okay, the other thing is reducing other risk factors. So you've got steroids, smoking, alcohol, dental trauma, diabetes, infections, chemotherapy, radiotherapy, and coagulopathy. So these are other risk factors that, when added to the bisphosphonates or the denosumab, will increase their risk. Okay. In terms of stopping denosumab, that's a slightly different story, which I will come on to a bit later, because as I said before, it's very reversible. It's not like bisphosphonates, which last in your skeletal tissues for years. So in the second page of this guideline, they basically help dentists decide when they need to contact their local MaxFax center, but you don't really need to worry about this. But the basic answer to a dentist who says, oh, I'm not going to do the operation on this patient because they're on bisphosphonate is to send them these guidelines and discuss it with them. Sometimes they're not aware of this, and they're not aware of the exact ways that these drugs work and the lack of benefit stopping them in the acute setting. So now denosumab and osteonecrosis of the jaw. So that was bisphosphonates and osteonecrosis of the jaw. So this was a very useful paper that came out last year in JCM, okay, by Nelson Watts and team. So invasive oral procedures, so that's things like extractions or implants, and events in postmenopausal women with osteoporosis treated with denosumab for up to 10 years. So they've got 4.5 years in total, the mean prospective follow-up, okay? And they've got, I'll show you here, they have got thousands of women. It's 3,591 women in this study. And essentially, they showed that women on denosumab, the risk of osteonecrosis of the jaw, if they had an OPE, so that's a invasive oral procedure and event, like an extraction, was 0.68%, tiny, less than 1%. And if they didn't have this extraction, it was 0.05%. So this is 3,500 patients. And you see the majority had mild or moderate osteonecrosis of the jaw, only one had severe. And usually all that was needed was oral rinse and some antibiotics. And 8 out of the 13 required some surgery. 11 of the 13 had resolved. So this is quite reassuring. So you can tell your patients that if you do get osteoporosis of the jaw, most likely it will resolve. The 2 that hadn't resolved, one was ongoing and one was unknown. So it could have been higher that had resolved. And this is the really interesting thing here, that 7 of the 8 cases who did continue their denosumab, they resolved. So despite continuation of denosumab, their osteonecrosis of the jaw went away, which is really quite reassuring for denosumab use. And we know we worry about the reversibility of denosumab, and if we stop it, we're going to lose all the benefits within 12 months to 24 months. I think someone's microphone is on.
7 continued on denosumab.
I don't know if Kareem, if you're there, you could try and mute the external microphone. So the reassuring thing here is that basically 7 of the 8 cases who continued the denosumab resolved. So with good dental care, good dentist, mouthwashes, maybe oral antibiotics, you can still continue denosumab. And this is a very useful information when liaising with dentists that you may have to do. And sometimes I send them this abstract when they get worried about the risks of osteonecrosis of the jaw when they're going to do a dental extraction. And I show them this data and say it's 0.68% is the risk. Okay, so my message here is it's good to do a dental review prior to starting a medication, especially if there's poor dentition. What is poor dentition? Well, in the sort of grossly, that would be wobbly teeth, okay? and complete any, I always tell patients to complete any urgent or impending work prior to starting on bisphosphonates or denosumab, if possible. And maintain good oral hygiene, twice daily mouthwash, and dental reviews early if possible. In terms of bisphosphonates, there's little point in stopping unless the dental work can be delayed by more than 18 months. That's for risedronate, or a couple of years for alendronate. And for denosumab, the risk of osteonecrosis of the jaw is very small, similar to bisphosphonates. It is higher if you have an invasive dental procedure, but it's still less than 1%. Okay, and even if they do get osteonecrosis of the jaw, most cases will resolve, and most cases that continue on denosumab will resolve. So this is because we don't really want to stop denosumab if possible, because of the loss of the gains and the risk of rebound multiple vertebral fractures. Sometimes some clinicians suggest doing, if they can wait for their dental procedure, to do it the 5th month after the denosumab injection, when bone remodeling is starting to wake up again, when you would normally start on the 6th month of their next dose, and you can delay their next dose by 1 month. So you give it between they have a window between 5 and 7 months after a dose of denosumab, where their bone turnover is slightly higher and therefore may be a good time. There's no published data on this, but this is a sort of caveat that some clinicians do in the field. I often send the abstract that I showed you, osteonecrosis of the jaw and denosumab abstract, or the UK MaxFax guidelines to the dentist with a patient to convince them to do the dental extraction because the patient is in ongoing pain, etc. Okay, moving on to the next topic, treatment failure. Okay, so you are referred a 72-year-old woman who has sustained a fragility wrist fracture despite being on alendronate for the last 3 years. So she's fractured on alendronate for the last 3 years. Nothing else in her medical history of note. She's compliant with her alendronate and taken it appropriately, and you perform a DEXA that shows no change in her bone mineral density since starting the alendronate. So bone mineral density has stayed the same, but she has fractured on alendronate. So what are we going to do? So let me share. Next question. Okay, so 72-year-old lady, fractured whilst on alendronate for the last 3 years, bone mineral density is stable. What are you going to do? So you're going to switch to risedronate. Are you going to switch to IV-Zol? You're going to switch to denosumab. You're going to measure bone turnover markers, or you're going to continue on the weekly alendronate. So switch to another oral, or continue the current alendronate. Maybe upgrade to IV-Zol or denosumab, or do you want to check bone turnover markers? Okay. Let's give it another few seconds. Okay, good. So the majority have gone for measure bone turnover markers, which is what I would do as well. Switching to risedronate would be no real benefit there. Equipotent, really, alendronate and risedronate. Switching to IV alendronate may be an option. The added benefit often in switching to IV alendronate from a patient who's compliant and absorbing their oral alendronate is actually quite minimal. Often the benefits aren't that great, but it could be an option if you're going to deem this treatment failure. And indeed, denosumab might be an option if you're going to deem this treatment failure. And continuing weekly alendronate would also be an option if you're not going to deem this treatment failure. But you want to really have a look, is this treatment failure? And I would therefore go with the yellow here, and I'll show you the criteria really for treatment failure. So, okay. So measure bone turnover markers, okay? So what do I do for patient fractures on a bisphosphonate? First of all, don't panic, okay? Check their compliance. Are they taking their bisphosphonate on an empty? Remember, only about 1% of an oral bisphosphonate is actually absorbed, okay? Only 1%. So you need to maximize this absorption. Firstly, you need to make sure they haven't got any causes of malabsorption. And secondly, you want to check that they are complying with it. Are they taking it on an empty stomach in the morning with tap water? Remember, if you take it with mineral water, there's a lot of cations, so calcium, magnesium in mineral water, which can impair the absorption of bisphosphonate by up to half. So tap water is what is recommended. And then they should stay upright for half an hour. And I tell them it doesn't mean they need to stand up. They can just sit. And that's fine, because I've had the odd patient who thinks they need to stand up for half an hour and find that very annoying. They are allowed to sit. It's basically to stop the tablet popping out of the stomach. Okay, so if you've checked their compliance, you don't think there's any other secondary cause, so that's like they've developed something else since then. They've developed Cushing's disease, or they developed celiac disease, or they developed rheumatoid arthritis, or primary hyperpara. Some other new thing has come on the scene, or they've been put on steroids. Then if there's no new detrimental factor for bone, then you can start to consider if this is treatment failure. Okay, so remember, not everything is failure. Bisphosphonates will reduce your fracture risk by about 40 to 45% for orals, but not completely. So there is still a chance of fracturing, and we have to allow this where reasonable. So what really constitutes treatment failure? So these are the sort of published guidelines on what would constitute treatment failure. And then you would start to think, maybe I need to upgrade the treatment. So 2 or more fragility fractures on treatment, not just 1, but 2 fragility fractures on treatment, or 1 fracture plus a failure to suppress bone turnover markers. So typically when you start, if you have bone turnover markers at your center, when you start a bisphosphonate or denosumab, this would also count for denosumab, you would expect your bone turnover markers to drop by at least 25% and into the lower half of the reference range. If they don't, then maybe they're not absorbing it properly, they're not taking it properly, or they're just failing to suppress their bone turnover markers. Another criteria would be or decreasing bone mineral density. And because of the error in the machine inherent in DEXA scanners, you can allow 5%. You basically need to have a drop of 5% at the spine or 4% at the hip before that is really a decreasing bone mineral density. And something to do with the least significant change and the error of these DEXA machines. Okay, so 1 fracture. So our case, for example, she had 1 fracture. Her bone mineral density was stable, so that is not met. But we want to know if there's a failure to suppress bone turnover markers. So that's why that was the correct answer. Another option for treatment failure is both that and that. So that's the failure to suppress bone turnover markers and a decreasing bone mineral density. Okay, so 2 fractures or more on treatment, or 1 fracture, and then a combination of either failure to suppress your bone turnover markers or decreasing bone mineral density, or that plus that, are the 3 ways to determine treatment failure, in which case you would then upscale treatment or look at maybe a parenteral route, etc. Okay, so my message here is, don't assume this is treatment failure. It might be fine to continue, and this may save you some referrals to the clinic, potentially. So use a combination of the number of fractures, their bone mineral density, and bone turnover markers to determine. So there are 3 things to look at to determine if they meet the criteria for treatment failure. And of course, the first thing, as I mentioned on the previous slide, check their compliance and check there's no new secondary cause that has developed since starting the bisphosphonate. Good. So I just want to, in the last 10 minutes or so, do a little bit of revision of the key points from the Osteoblast series so far. Okay.
Before we do that, could you put the QR code, or should you want me to do that?
Oh, yes. Can you do that? Yeah.
I'll do that. I'll share my screen and just show people the QR code. just for a minute. And there's some questions on the chat that you could answer while I'm doing this.
Okay, let me have a look. Okay.
Okay, everybody, just to remind you, you need to take a picture of this QR code, and please could you feedback and put in your details, and we will use this eventually to send you your certificates. We need some feedback. That's an insistence of the RCP. Alex, you want to answer those questions, and then I'll turn this back off and you can carry on.
So, Catherine Bishop, what do you do if a patient hasn't seen a dentist for decades and refuses to see one but needs bone protection? I've had a few of these, you say. Yes, and yes, I mean, when you tell a patient to go and see the dentist, especially during now, it's never really going to happen. I think what I normally say for inpatients, the hip fracture teams and things, is if they got wobbly teeth, I would definitely not stop it. It's worth having a look at the dentition to check that there's nothing, to your expertise that looks particularly worrying. There's no abscesses. Basically, signs of infection is what you don't want. I would probably start them on, get them to start on mouthwash and good dental hygiene. If there's no wobbly teeth, depending on their risk of fractures, you may advise to start it. Will the bone turnover markers after recent fracture be reliable? No, they won't. So yeah, that's a good question. So often about a year, sometimes they can take up to a year for bone turnover markers to get better. So that's an important caveat in terms of when you're identifying patients who may have treatment failure or not. Alison Wren, hard water versus soft water. It's all about the amount of cations. So whichever has the least cations, so the calcium 2+, magnesium 2+, are typically the ones that are the highest in mineral water. Whichever hard or soft or filtered water has the lowest, that would be fine. I think filtered water should be fine. How do we manage osteoporosis in post-ONJ recovery? So that's a difficult question. How do we manage osteoporosis in post-ONJ? So, I mean, sometimes you can use teriparatide if they merit it, or you may liaise with the dentist. How well has it healed? How severe was it? How much better is that oral hygiene than it was before? Do you want to go in with, alternate week alendronate to start with and see what happens? I've done that once or twice, and to see what happens for the first 6 months and take it from there. Those are the options. George,
okay. Listen, I'm going to turn this off and you can carry on with the revision now.
Okay, let me just do George's question. It's difficult for the patients not to consider it a failure if they fracture onto it. Do you have any advice? Yeah, so that's a good question from George. Yes, they may feel it is a failure, but if you tell them that by giving you this medication, I have approximately halved your risk of fracturing, but there still is a risk of fracturing, and because you're taking it correctly and because you're fully compliant with it, you've only had this one fracture. You may have had 2, 3, 4 fractures if you weren't taking it. So it's very unfortunate, but sometimes this happens. And depending on their overall fracture risk, and it's very individualized in osteoporosis, what you do. There may be times when you feel that they may benefit from changing their treatment. Okay, so now we go on to the revision. Let me try and share my screen. Okay, so here's some revision of just some key concepts so far that I just wanted to reiterate to you. So in terms of risk factors and secondary causes of low bone mineral density, remember it's very important to, on your first meeting with a patient where you've been asked to make a management plan regarding their low bone mineral density, to assess their risk factors and secondary causes. And anyone who's done my clinic with me will know that I don't let a letter go out to a GP without a proper comprehensive assessment of risk factors and secondary causes. So over the lifetime, that would include previous fragility fractures. Remember, having one fragility fracture, it gives you a vastly increased risk of more fragility fractures, because it means that your low bone mineral density actually has a clinical consequence, just as a high blood pressure with a stroke is much more worrying than just a high blood pressure on its own. Okay, so severe illness during lifetime and immobility, anything that means you have less estrogen exposure, history of low BMI. So in terms of the testosterone story, which maybe I can cover in another talk that Channa was talking about, most of the data in the bone field is that testosterone is only beneficial for bones if it's less than 6.9, because you only need a little bit of actually the estrogen that is aromatized from that testosterone. You need a little bit to maintain bone density in terms of that side of things, in terms of the reproductive interaction with bone. So 6.9 is normally the cutoff there. A history of low BMI, obviously anything under the weight of 57 kilos increases your risk of low bone mineral density. Malabsorption, of course, rheumatoid arthritis, or any inflammatory disorder that releases cytokines, interleukins, etc. They will interrupt bone turnover. And obviously all the endocrine disorders that you know of. And there are other slightly rarer diseases, multiple sclerosis, myeloma, MGUS. So MGUS can do it. I've picked up a few cases of MGUS in clinic, although MGUS is quite common in the general population. Mastocytosis, so we have several patients with mastocytosis, where the mast cells release all these histamines and can interfere with the bone. The sarcoid, collagen disorders, including osteogenesis imperfecta, HIV, as well as the HIV medications, especially tenofovir, will increase your risk of low bone mineral density. We've got a few patients with hypophosphatasia as well. Lots of medication causes of low bone mineral density, which you can see listed here, such as high-dose statins, probably because it might interfere with your reproductive hormone synthesis, because don't forget cholesterol is a precursor of reproductive hormones. PPIs, so in America you can get calcium citrate. Here it's calcium carbonate, really, unless you spend the big bucks and go for Solgar calcium citrate. So PPIs interfere with calcium absorption in the gut, especially calcium carbonate absorption. So switching to calcium citrate can improve calcium absorption. Family history, especially parental hip fracture, is very important. And in their social history, smoking, so the cadmium in smoke is very toxic to the bone, and alcohol, anything 2 or more or 3 or more in women or men respectively, increases the risk of low bone mineral density. And of course, you don't break anything if you don't fall. So a history of falls is very, very important. So correct use of T and Z scores, always a contentious issue, but not really a contentious issue in the bone field, but outside the bone field. Why do we use these and not these? So remember to use T-scores in a postmenopausal woman. That would include a woman who has premature ovarian insufficiency, or a man above 50, or in a patient who's had a fragility fracture. Okay, so these are the 3 times when you would use a T-score, and it is correct to use a T-score. And a Z-score you use otherwise. And the cutoffs, remember, are -2 to +2. Anything lower than -2 is low bone mineral density for chronological age, which would make you think about maybe secondary causes. Okay, so we shouldn't really be talking about osteopenia in a premenopausal woman or a man under the age of 50. We should be talking about whether their bone density is normal or not for their chronological age. So why don't we just use T-scores? Well, essentially, it's because, well, here's a graph. Let me explain this first. So this is 5-year fracture risk. So in the next 5 years, what are their risks of fracturing for different ages, dependent on the same T-score. So if their T-score at the age of 50 is -3.5, and you can see what happens to their risk if they maintain that T-score -3.5 at the various ages. And you can see it splays out, especially beyond the age of basically the postmenopausal range. But before that, they're all very close together, okay? So it's not really meaningful to talk about t-scores because it's just a very small multiples of a tiny absolute risk. So it's not really meaningful, whereas it's much more meaningful to look at the Z-score, which is them compared to their peers. So it's matched for age, and see if they're more than 2 standard deviations below their age, which is a normal way of establishing a reference range. Okay, and then if it's more than 2 standard deviations lower than their reference range, as it were, for their age, then it would make you think something's going on. Is there any other secondary cause, for example? Okay, and the reason we need to have t-scores is actually because you need to be able to define osteoporosis. If you just use z-scores of -2 or less being low for chronological age, then that would not really define this increase in osteoporosis as you get older. Okay, because everyone would be within -2 to +2 no matter what their age. Okay, so managing patients with upper GI symptoms on oral bisphosphonates. So that's also a very common referral that you will get to your clinics. What are some ways to approach this? Well, firstly, bisphosphonates are quite toxic on the gastric mucosa. They cause epithelial loss. They get increase in these cytokines and infiltrates and mucus problems and collagen degradation. So it's very common. And most studies show approximately 30% are still taking the bisphosphonate 1 year on, unless they're really closely followed up. So compliance is quite poor at 1 year. So it can be minimized by correct dosing procedures. So just telling them to take it properly, empty stomach, glass of water, sit upright for half an hour afterwards. Just telling them that will mean a lot of patients are able to tolerate it better. It's very important that they use the correct dosing procedures. Alternatives are switching to risedronate. So I've had some success. There's no published data on risedronate being better tolerated to alendronate, but I have seen a few patients where, perhaps there's some psychosomatic or functional element to it, but, they have tolerated the risedronate better, which is also weekly. In some cases, I might suggest once a month ibandronate, because that psychologically is a tablet once a month. It's less beneficial than alendronate and risedronate. It has no fracture data on hips, unlike alendronate and risedronate, but in very mild cases, you may be okay to switch to ibandronate. Then there's Benosto, which is a pH buffered, gastric friendly version of alendronate. It's available in Northwest London. It does cost about £23 a month. It's still cheaper than bringing them in for annual IV alendronate infusions and appointments. Okay, so that's Benosto, and I've had a lot of success with patients by just telling GPs to switch to Benosto, and that's what we do with our fracture liaison service. They get options of what to do if the patient doesn't tolerate the first line alendronate. And then obviously the options are IV alendronate and Denosumab, the parenteral antiresorptives, and often they need to be referred to our clinic for that to be started. Okay, and then quickly FRAX, and remember to use the femoral neck bone mineral density. So FRAX really comes into its own for osteopenic patients. Okay, patients with osteoporosis, normally they should be on treatment. Okay, but it's the osteopenic ones, because remember, most people who fracture are actually osteopenic because of the sheer number of people who are osteopenic out there. FRAX is very useful for identifying using their bone mineral density or not, together with other risk factors that have been identified, whether these people are high risk. And there's actually a movement in the field to redefine osteoporosis as your risk of fracture and not based purely on a T-score, as it was set up in the 90s. So remember, you put in the age, their sex, their BMI. Doesn't really make much difference unless it's in the very low BMI range. Whether they've had a previous fracture, parental fractured hips, smoking, steroids, rheumatoid arthritis. Secondary osteoporosis, it doesn't make a difference if you tick no or yes, unless you haven't got the bone mineral density. And remember, for the bone mineral density, you should put the raw number, so 0.750, for example. You don't put in the T-score because the T-scores are set up differently depending on how your machine is set up. The T-scores that you can enter onto FRAX are only the ones that are set up using the Enhance 3 database, and most places aren't using that. So it's best to put in the actual raw number, and it's the femoral neck, not the total hip, but the femoral neck number that you need to put in. And you get your risks down there, and then you can plot easily there. You get this as your intervention threshold. So you can see here someone with a osteopenia, and their T-score is actually minus 2.1, because the FRAX will then work out once you put it in here. But because they've had a previous fracture and a parental hip fracture, they're well in the red zone here, which is to treat. Okay. And quickly, the last thing I think is management after 5 years of an oral bisphosphonate. So typically we start with 5 of an oral or 3 of zileginate. Okay. And obviously you're balancing benefits and risks. Okay, so the benefits are fracture risk reduction, and your risks are the ONJ and the AFFs. So after 5 years, so when you get referred a patient, this patient's been on a bisphosphonate for 5 years, shall I continue or shall I stop? These are essentially the criteria in the UK for continuing. And it's the criteria that identify these high risk patients where the benefit in continuing outweighs the risk of stopping. Okay, so 75 years old, if they've had a hip or vertebral fracture or any fracture during their treatment, if they're on high dose steroids, and if their hip BMD is less than minus 2.5, or if they're above the FRAX thresholds. So these are the 5 criteria that identify these high risk patients. If they don't fall into this high risk, you will then stop for a bisphosphonate holiday, which will vary according to the medication you're using. You may stop their holiday, a fracture obviously, and they will need reassessment. American criteria are quite similar. The only major difference is they also use the spine 5-year point. I think someone's microphone is on. Okay, so remember these. So if you're in the UK, 75 years, any previous hip or vertebral, so these are the major fractures or fracture during treatment, steroids, hip, T-score less than 2.5 and above the threshold. Sometimes I write to the GP and I give them this when I've started a patient on an oral bisphosphonate, so they don't then come back in 5 years' time. Because really, we shouldn't be seeing very many patients with on oral bisphosphonates in the clinic. It should be really the more severe patients. Okay, so thank you very much for listening. I hope you found that useful and the revision session useful, and I'll see you next time. I'll see if there's any questions now. So chat.
Thank you, Alex. You got anything else to share? Do you want to share the?
Yeah, I'm going to have a look through the.
Oh, I'll do it if you like.
The chat. Would you suggest routine HIV testing in all patients with osteoporosis? I would not, unless there are additional risk factors. I haven't picked up a patient who's got HIV purely because they've been referred with low bone mineral density, but I have seen it in reverse. And because I do my clinic at Mary's, in the building opposite, we have a big HIV center, so I see a lot of their patients there. But sometimes I have done it in the odd occasion where I can't explain why their bone density is so low. You know, sometimes you can use it then when in your screening for really oddly low bone density in a patient. For high-risk patients, we need at least one criteria to continue beyond 5 years. Yeah, for high risk, no, we just need one of those would do it. So just being over 75 would do it. Do you need a DEXA for all fractured NOF or vertebra, given they will likely be had? Yeah, so that's a very good question from Catherine. So you can define osteoporosis on just having a fragility fracture. So in which case you don't need to do a DEX, but it depends on how you're set up. In some places, it's good to try and get a DEX at baseline, although you would start medication in hospital, it would, you probably want some sort of baseline DEXA later on, so that you can then make comparisons depending on treatment progression, or if they refracture and things like that. Also, you may pick up if the patient's got really low T-scores, like -4, -5, and you may then start considering teriparatide rather than just sort of an oral or a IV bisphosphonate. Do you repeat Frax on alendronate for 5 years? No, so Frax is only designed for treatment-naive patients. It's a tool for you to decide if you should start someone with osteopenia on treatment, essentially. Okay, so it's not really that useful. I know the NOG guidelines use it. You can use Frax at the 5-year point to help you decide if they're high risk. I don't often use it that much because use it in that way. It's not quite as pure, and not what Frax was really set up for. For steroids on Frax, would you click yes even if the patient is on physio? Yeah, so that's, I think, I can't remember which session that was, maybe part 4 or 5. If you look back on the recordings, I went through all the various types of replacement, supraphysiological versus physiological replacement. Essentially, I would click no if it's physiological steroid replacement, unless it's slightly above the physiological dose. For example, if they're on Pred 5, might be a bit too much, I might be tempted to click it. But remember, there is, it's very individualized. There's no often correct answer, and you can often argue either way on whether you're going to start a patient or not. There are other really useful things which are looking at serial DEXA scans, seeing what's the trend in their bone mineral density. Okay, it may not be quite above the treatment threshold, but it's dropped so much over the last 5 years that maybe I want to intervene now before it, rather than just wait another 2 years when it will have dropped. Other criteria, I've just stopped, I've stopped their HRT now because they're 60 years old. Obviously, it's going to start dropping. It's like going through the menopause again. And during the menopause, you can lose up to 2% of bone density per year. So you may want to intervene at slightly higher threshold. So it's very individualized approach that a lot of, those who sit with me in clinic have sort of got a feel for. I think that's all the questions. Thank you very much, everyone.